Next, after the part one, we discussed about the part one of the webinar. We discussed about the various elbow joints, the humeroradial joint and the humeroulnar joint, and the mobilizations for that. And next, I'll be first showing you the various stability tests. So, coming to the elbow joint stability test, we have the valgus stress test. I'll show on the pre-recorded video first so that you have some preliminary understanding, and then these are the various ligaments. And we have the tests. The valgus stress test is to check the integrity of the medial collateral ligament, and the varus stress test is to check the integrity of the lateral collateral ligament. And then you can see here I'm going for the pistal grasp. You can see the pistal grasp, and so I'm palpating with the index and the mid finger in the medial aspect of the joint line. That is the valgus stress test. And my other hand is kept. You can see I'm giving the valgus stress from lateral aspect to medial. And we have to compare always in orthopedic test in both the sides. If the opening up is more than 1 centimeter, then the test is positive, suggesting instability to the medial collateral ligament. You just see here, I'm doing the pistal grasp and then palpating, applying the force from the upper lateral aspect of the forearm. That is the valgus stress test. And then next, in the varus stress test, we have to palpate the lateral aspect of the elbow joint and upper medial aspect of the forearm. The force is applied from the medial aspect laterally. Elbow is slightly flexed, and we have to, because yes, we apply the force from the medial aspect laterally, and while we are palpating the aspect of the joint. If the opening up is more than 1 centimeter in the lateral aspect, we have to compare with the other side. Then the test is positive, suggesting instability to the lateral collateral ligament. So after this, I'll be doing one live demonstration on the subject, and because I'm repeating some of the important things, because we have a lot of professionals and students who have enrolled and they're seeing. So this is meant for all the physiotherapists and physiotherapy students. And lateral pivot shift test. Integrity of the posterior capsule of the elbow joint. You see the arm is flexed, externally rotated, and the forearm is supinated. It sometimes appears because it is elevated, so somebody might be thinking it is pronated, but actually it is supinated. The elbow is taken for slight flexion. Valgus stress is applied, and then axial compression has to be applied. Valgus stress, axial compression, and maintaining that. The arm is taken towards extension and the elbow is taken towards flexion. And if there is subluxation followed by relocation, then the test is positive. First is valgus stress test, axial compression, and then you bring the elbow towards flexion and glenohumeral joint towards extension. So I'll just demonstrate these 3 techniques now. Yes. Right. Okay. Right. So first is the valgus stress test. Those who have maybe issue with the visibility, you can refer I'm just repeating it. I already showed on the a pre-recorded video and showing the live technique also. You see this is the pistol grasp and palpating for the medial aspect of the elbow joint, and then the fast wave space is kept at the upper lateral aspect of the forearm, and then applying the force, elbow is slightly flexed, applying the force from the lateral aspect medial, and we have to repeat for both the sides. And if the opening up is more than 1 centimeter, the test is positive, suggesting instability to the medial collateral ligament. And then next is the varus stress test. You palpate the index and the mid finger in the lateral aspect of the elbow joint. The first wave space is upper medial aspect of the forearm, and then apply the force. The force is applied from the medial aspect laterally. And as I said that already this I have a more clear visibility I have already shown. There may be angle issues, and you know we are in lockdown period, and then they're getting a professional, right? So whatever best is possible we are doing from our side, index and mid finger. So definitely it is not like when we are attending the workshop and live learning, obviously technology can help us but cannot compensate for it. So obviously I also understand that what we cover in our direct workshops, that is not possible to cover through the webinar, but this is the best what we can do right now. The index and mid finger, lateral aspect of the elbow is slightly flexed, and you are giving the force from the medial aspect lateral. You compare both the side. If the opening up is more than 1 centimeter, there is instability to the lateral collateral ligament. The next, coming to the lateral pivot shift test. Lateral pivot shift test, we are putting the arm for external rotation. It is elevated and right. And the elbow is taken for extension, forearm is supinated. From here, elbow is taken for slight flexion at first. Elbow is taken for slight flexion. Give a valgus stress. First a valgus stress is applied and maintain that. And then we are giving the axial compression. Valgus stress, axial compression. Then the elbow is taken towards flexion and the glenohumeral joint is taken towards extension. If the olecranon subluxates and followed by relocation, then the test is positive. That suggests there is instability to the posterior capsule. Suggests instability to the posterior capsule of the elbow joint. So I showed you the valgus stress test, the varus stress test, and the lateral pivot shift test. And these are the two important tests, or three important tests for the ligaments. I'll show you the Mills maneuver, what we are doing for the tennis elbow. So just sit down here. It's a very important maneuver for identifying the, yes, sit down, right, okay. So the Mills maneuver, it is useful for the, I discussed some of the important mobilization and the stability test. Next, coming to the management for the identification and some of the maneuvers. This is one test, Mills maneuver. So the arm is abducted. Maybe while you are listening to the talk, you yourself can do it. The arm is abducted. The elbow is flexed for about 20 degrees. The arm is taken for internal rotation. The forearm is taken for pronation. The wrist is taken for flexion. And taking all these components, the elbow is taken towards extension. And then you can give a small thrust. So basically in Mills test, we are going for this position and the pain is felt. That is the Mills test. And the Mills maneuver is you are going for this position, arm abduction, elbow flexion, internal rotation, forearm pronation, and wrist flexion with ulnar deviation. You go for extension, go to the barrier and give a small thrust. You are going to get when there is and what it is very helpful for the chronic tennis elbow. If the condition is little older, there is cross linking of the fibers, and in those conditions this maneuver, the Mills maneuver, is useful for the assessment and the thrust. And maybe if you can do it with me, that will be good. And if you can experience the stretch itself on your lateral aspect of your elbow or slightly above that. You abduct the arm for 90 degrees, elbow is flexed for about 20 degrees, and arm is taken for internal rotation, arm you take it for pronation, wrist is taken for flexion, and then you go to the barrier and give a thrust. So that is how, if you are doing this position, you can experience there is a pull, and then when there is cross linking, that time you can go to the barrier and then you can apply the thrust, and it is very useful for the treatment of the tennis elbow. And I'll take you through one of the topic what I have written in my book on this is the clinical symposia in manual therapy, and the other book I have written is manual therapy of the pelvic complex, and I'll take you through just support this through the topic on the tennis elbow, and you can see this is the area where the pain is experienced, and it is definitely repetitive stress activities for the carpenters and these things. So I'm just putting some ideas so that I'll be showing it on the techniques what we can do. And primarily we have the involvement of the ECRB, the extensor carpi radialis brevis is getting affected, and the ECRL is not affected. Usually it is the ECRB which is affected, because right. So what happens is the extensor carpi radialis longus. I'll just tell you what is the prime cause. The longus is attached to the base of the second metacarpal, and the brevis is attached to the base of the third metacarpal. That is what I've explained in my book about when I'm discussing about the tennis elbow. So that's why ECRB is getting primarily affected, not the ECRL. So what are the important techniques? We can go for the deep transverse friction techniques. You can see here, I'll be showing this also. Mills maneuver, I just explained. The arm is abducted, then elbow is flexed, forearm pronated, and then that's how we are going for the barrier, and we are giving a thrust. And we have the radial head mobilization, which already in the part 1 of the video I have already explained, where we are palpating the radial head and mobilizing it, because many times, although it is a muscular involvement, but it is going to affect the joint also. And then we can go for the radial nerve mobilization. And the multimodal approaches are always the best, and then we can go for the tapping techniques. That also I am going to demonstrate. And then this is how we go for the pre-wrap, and then we can give the brown tape, and there is a diamond tapping also. That is also applicable. And this is the flex bar training. You can see here the flex bar training, because sometimes what happens when we go for the transverse frictions also, and then we go for the Mills manipulation also, we are of course as physiotherapists, we are using certain times the electrotherapeutic modalities also. But then what happens is, after certain time improvement, suppose 40%, 50%, 60% improvement happens, and after that there is no improvement, and if you see, you can find the muscle weakness is there. That time you can go for the flex bar training. And then I will just show you how to apply the flex bar training, and and this book, somebody was asking, this is available in Flipkart, Amazon, and also you can visit our website and you can see that. This is very useful. Along with the mobilizations, you can go for the flex bar training. You can go for this. This is I have 2 different colors I'm showing. This is with less resistance, and this is with more resistance. What you can do is, you can take the wrist for extension. Say right side is affected. We are putting the wrist in extended position for about 20 degrees of extension position. You can keep it, and then the other side you hold with the other hand. While you are maintaining this extension, you just twist it anteriorly, just rotate it anteriorly, so that this particular stress, when you rotate it, and you can go to the barrier, and then you hold it in the, and when you rotate it, you will have the recruitment of the muscles, because that stress what you are creating here, that is going to be held by this extensor carpi, basically to work on the ECRB. As I told you that it is in tennis elbow, it is the extensor carpi radialis brevis which is getting affected. And let me just explain here why ECRB and why not ECRL. Because the ECRB is attached to the third metacarpal base. This is the third metacarpal base. And the ECRL is attached to the second metacarpal base. So because it is attached to the third metacarpal base, so it is the most powerful midline extensor, extensor carpi radialis brevis. The cause why it is getting affected, that maybe many students might not be knowing, or maybe knowing, but the prime cause why ECRL and what is the difference between ECRB? It is the ECRB which gets affected because it is attached to the third metacarpal base, and that is the most powerful midline extensor. ECRL is attached to the second metacarpal base. That is the prime cause. And for racket sports, when somebody is using the racket sports like badminton, tennis, and even we have seen like cricket legends like Sachin Tendulkar also had tennis elbow. So any sports activities, or the carpenters, somebody who is especially when they're drilling it, somebody railway track workers, we have seen many people coming with that pain in the lateral aspect of the elbow. So you need to check whether another important thing. Now suppose somebody is coming with the lateral aspect of the elbow pain, how to identify, is it a joint involvement or it is the muscular involvement? So what we can do is, in that case, now suppose you rule out that is it joint involvement or it is muscular involvement. How to rule out? Is it a joint problem or muscular problem? The joint problem, you go for the direct palpation. I already have explained. Muscular involvement, what you do, you can go for the test, as already told, Mills test you can do for. Another most important test what you can do is registered isometrics. Registered isometrics, you ask the person you can put the elbow in slight flexion and ask the person from the wrist, you ask the person to extend the wrist, just extend it. So, and this extension of the wrist has to be registered. So when you register it, that if it is muscular involvement, this is called a registered isometrics. When you register, if it is muscular involvement, the pain is going to elicit. The same pain comes with muscular restriction, that is the muscular involvement. And you palpate directly, then you get the pain on the joint, that means it is joint involvement. How to go for the neural involvement? Then we can go for the neural tissue testing. So basically, just lie down. I already explained that lie down. For the radial nerve, so maybe if you want to experience your own neural stretch, then you can do the maneuver. What I'm going to do on the model, I'm demonstrating now. You yourself, while you are listening to the talk, you yourself can do it. You see the arm you abducted for about 40 degrees. While you are listening to the talk, you can do it yourself. Arm is abducted for about 40 degrees, and you hold the thumb with these 4 fingers. Arm is abducted. Then what you do? Arm is internally rotated. Arm is internally rotated. Forearm is pronated. Wrist is taken for flexion. At the same time, you can take your scapula for protraction and depression. The scapula is taken for protraction and depression. 40 degrees of abduction, arm internally rotated, pronation of the forearm, wrist is flexed, and then what you do is you can some kind of stretch, side flex to opposite side, and then you can go for abduction. If you are getting the stretch, now suppose you want to confirm, is it due to the nerve or not? Once again I'll tell you, hold the thumb with these 4 fingers, arm 40 degrees abduction, and then from there protraction and depression, arm internal rotation, forearm pronation, wrist flexion, you go to the abduction. Suppose you are getting a stretch, then side bend to the opposite side. If that pain is elicited, then it is due to the nerve. So this is how we differentiate. Again I'll tell you that lie down oblique position. I'll show you that head this side, okay. Subject in oblique position. Yes, right. So already I explained the position, because that full view may be possible, may not be possible. So use your all those components what I have discussed, I'm going to demonstrate here. So protraction and depression of the scapula, just come this side. That's why we are putting the subject in oblique position, so that we can maintain the scapular position. The arm is abducted for 40 degrees, and then the forearm is pronated, a flexion of the wrist, and then this is how, if the pain is elicited, this is how we go for the neural tissue mobilization. And along with your treatment of the tennis elbow, yeah, just come this side. Okay, so what are the treatments for the tennis elbow? What we can do, one is deep transverse friction massage. Deep transverse frictions, you identify the tender point, then you can go for the deep transverse. You can use your thumb or you can use your index like this, and that's how. And suppose there is a lot of irritation, then in that case you can go for the PRT, positional release technique. So you identify the pain submaximally, you find the tender point, and then you take the elbow for flexion and then take the wrist towards extension, do the fine tuning with supination, and maintain this relaxed position for about 90 seconds. So this is how you are going to apply the positional release technique, and if there is a lot of pain and irritation. And MFR, myofascial release techniques also you can apply. MFR techniques, once the pain intensity has reduced, you can use your fist you can make, or you can use your hypothenor contact, and from elbow flexion you just move towards elbow extension while you are applying the myofascial release. Then we are moving towards the cubital fossa. Basically the rule is that we have to move towards the nearby lymphatics, and this is how you can repeat it. If there is a chronic tennis elbow, there may be gross fibrosis, there may be enhancement of TNF alpha factor or TGB beta factor, and there are a lot of studies which have proven that when you give the transverse glides, that time the cross fibrosis that actually reduces. So that is one thing. So you can, along with the treatment of the muscle components, we can go for the joint mobilization, we can go for the neural tissue mobilizations, we can go for the tapping techniques. So here I will just take 1 minute break, so that I will just make my arrangements for the tappings, so that I will show you some tapping techniques and some more flex bar training treatments for the elbow complex, and some more associated issues in the pronator teres muscle, and some neuropathies that also I'll discuss. Just I'll take a 1 minute break.